My name is Greg Kolovich. I'm an orthopedic surgeon in Savannah, Georgia. I work at Optim Orthopedics. I did my residency at Ohio State. I did my hand and micro training at Harvard, Mass General. Before the Ocelot, I used, like any other surgeon, numerous methods: therapy, counterforce brace, even dry needling, steroid injections, of course, and I did PRP in the office. And then, of course, as a last resort, open debridement with reattachment with anchor fixation. So therapy doesn't always work. For me, it's always been about 50-50. It can be time-consuming, expensive, and you really just don't get that quick fix that patients are looking for. Patients are becoming sort of impatient with the process, which is good. They want to get back to their activity, and therapy can be, it just, in my experience, doesn't always, fit the bill. Steroid injections work somewhere between 50 and 75% of the time, and sometimes I have to come back and do repeat steroid injections. The problem with steroid injections is they can stain the skin, they can cause subdermal atrophy. You can't really do more than one or two. Patients sort of rely on them as a crutch. It doesn't work as successful as you'd like. But you really regret having a patient with thin skin causing subdermal atrophy or skin bleaching. I've even seen open wounds, chronic wounds from prolonged steroid use. So that's always troublesome. I don't like to do more than one or two. And certainly if I do two, I like to spread them out as much as possible. Surgery works. Surgery does work. There's two methods of treatment. Some people go in and release the tendon. I prefer to go in and debride it and then reattach it with a suture anchor. But surgery, there's no doubt in my mind that surgery does work. It is for all intents and purposes the gold standard, but it's expensive. It's also very time consuming. It's painful. It's not the first option. If there are more conservative treatments, certainly we need to explore those. I've always been partial to combining PRP with a debridement, with a percutaneous debridement. So that led me to the Ocelot, because it does two things. It gives you that percutaneous debridement that you can get with dry needling or even a peppering with a steroid injection. But then you can also use the cannulated needle to add the PRP, which I think really helps. So I get to marry two technologies that I like: the dry needling, the part we can actually sort of debride the tendon, get in it, and it has that needle technology to go in and debride the denuded tendon. And then it also has the cannulated needle in it, so I can harvest the PRP and then insert it, inject the PRP right through the cannulated needle with the help of the ultrasound. So I think it marries two technologies that I like, all done through non-surgical percutaneous options, faster recovery, better healing, and I'm showing somewhere between 90 to 95% success with that. PRP alone can be expensive. Insurance doesn't cover it. At least many insurances that we deal with don't typically cover it. So that's always a challenge, is getting people to pay out of pocket. PRP does work. I believe in it. It's a regenerative technique that's been used for 30 plus years. And, it makes total sense to me to harvest the platelet-rich plasma in your blood, concentrate it and inject it into a tendon. So that has been proven. The expense is really the main challenge. Insurance companies just don't always cover it. The problem is you need to get it inside the tendon. So the Ocelot allows us to do that through ultrasound guidance and having that needle, being able to debride the tendon and get inside of it. To debride a spur if you need to, the Ocelot can actually go in and debride that spur right off. You can get right under that tendon, as we'll show in the videos, and after you've debrided it, your needle's in the right spot to inject the PRP where it needs to be. So I think marrying the PRP with the Ocelot is extremely helpful, and we'll bump those success rates north of 95%. I think a big part of it, when you look at key performance standards, you have to look at the success rate. You want to do something that is certainly above 90%. You don't want to do things that are a coin flip, 50-50. That's not a good treatment. So when you look at PT therapy, in my experience, it's really sort of 50%, maybe 50 to 75%, not north of 90%, where most surgical results are. So you want to get it as successful as possible. But then you also have to look at, well, how long is this going to take and how expensive is it going to be? Because if this is going to take 6 months to get better, That's a lot of time for people to take off of work and to rehab from. So you want to marry the rate at which you can return to activity, we would call your recovery time, with the success of the procedure. And, while surgery is extremely successful, in my opinion, it can take 3, sometimes even up to 6 months to get back to where you want to be. So we're always looking for treatments to shorten that recovery time. And I think doing an Ocelot TendoNova procedure with PRP injection, I think you're going to find that the recovery is much faster. The expense certainly is going to be far cheaper than doing open debridement with anchor fixation. So you marry a lot of key performance measures that I value, and that is, a faster return, less pain, and of course, everybody's happy when you can make it cheaper, because I think people are going to, it really shortens the burden, or it really lessens the burden for the third-party payers that are having to pay for these procedures, or even out of pocket for our patients. So you want something that's fast, effective, minimally invasive, less pain, and of course, less expensive for everybody. So the Ocelot has some competitors. I think that one of the main advantages is the setup. It's battery-powered, wireless. It's very easy to set up. You can set up in less than 5 minutes. I do like the cannulated needle. I like the fact that you can go in, it's sharp enough to debride the tendon, of course, but also debride a spur if you need to. Having the ultrasounds there, because you can actually see the tendon, you can see the lateral epicondyle in real time. You can see whatever you're debriding, whether it's the elbow, the Achilles, you name it. And you can see your soft tissue and your bony anatomy with the ultrasound. You can put your needle directly where you want to go, do your debridement. And then you can simply remove the device, and you have a cannulated needle if you want to inject PRP, which is pretty helpful. Other devices don't have that cannulated option. So once you get that needle, which is really half the challenge, getting it where you want, you have that option to remove the battery-powered device and then inject the PRP directly where you want it. So if you look at things that the Ocelot can treat, a lot of tendinopathies, lateral epicondylitis or tennis elbow, medial epicondylitis or golfer's elbow, Achilles tendonitis. You can use it for plantar fasciitis, patellar tendonitis. I mean, a lot of the tendinopathies is typically what I use it for. I think there's some potential in the shoulder as well to treat these tendinopathies. The nice thing about it is it's all percutaneous. There's no incision. Anytime you make an incision, you have to dissect down. More dissection, more swelling, more post-operative pain or post-surgical pain. So you're mitigating all of that by using a percutaneous needle. You have the ultrasound to help you through your landmark, so you can get the needle exactly where you want. So I think those are all advantages of the Ocelot. But yes, I mean, for me, when I sell it to patients, their first question is, does it work? We know the success rate's north of 90%. In my experience, it's been around 92 to 95% successful. We know the recovery's quick. Most patients are getting good results within 6 weeks. I really don't see patients that are having the pain-free exam from surgery until somewhere between 6 and 12 weeks. Here I'm getting it somewhere between 4 and 6 weeks, so there's definitely a shortened time, and that makes sense. You're not getting less. You're not getting swelling. You're not getting that 2 weeks of post-operative pain. There's no stitches involved or anything, and you can get them moving right away, which really helps with their range of motion, so they don't get stiff or anything like that. So I think we always need to be striving to do techniques that work, that are more minimally invasive, more cost-effective, and this accomplishes all of that. So in clinic, I see in an average 80-person clinic, I'll probably see somewhere between 5 and 10 people with legitimate tennis elbow. And both men and women, young and old, it's usually between the ages of 30 and 60. It's sort of a disorder of middle age, but it's extremely common. And I'm just using tennis elbow for one example. And most of them, when they get to me, they've tried some form of physical therapy, anti-inflammatories, maybe even a topical anti-inflammatory, and sometimes even a prior injection. So I typically get people who referred from primary care or even other surgeons who had tried injections. So when they come to me, about half the time they've already had a recalcitrant treatment. So they're here for a second opinion, takeover care. So You know, Einstein said doing the same thing over and over again and expecting a different result is the definition of insanity. So I try to, you know, heed that advice in my practice. So I offer them alternative treatments. Some people, very few people come in and say, I want surgery. This is not what they say. They say, I don't want surgery. That's the first thing. And I don't want another steroid injection. And they've already usually had therapy. So where do you go? You're kind of stuck. You can't offer them surgery. They don't want another injection because they've had a stained skin or they've had subdermal atrophy. You have to offer them a novel treatment. And I think that's where Ocelot fits in, is because it is a novel treatment. We know it's going to be more successful than therapy and a steroid injection. And it's not going to have all the pain and expense and recovery time that's associated with surgery. So it is a nice marriage. It offers patients, and these are tons and tons of patients. This is a very common disorder. An alternative to surgery that's better than therapy and this cortisone injection. So it actually sells itself. And that's just one disorder. We can get into golfer's elbow, we can get into plantar fasciitis, Achilles tendonitis, patellar tendonitis. I mean, there's tons and tons of uses for it. But I have, early on in my adaptation of this, I found it to be incredibly successful for golfer's elbow and tennis elbow. My first patient was someone who was a workers' comp patient. Those can always be tricky. And the patient who had surgery, so he had a suture anchor buried in his tendon, and then did well initially, but then I injured it again. I didn't treat him originally. I treated him as a second opinion or takeover care. And he was very hesitant to do surgery again. He had tried therapy and anti-inflammatories. He even tried dry needling. I think he had a steroid injection as well. So he's pretty much gone through the gamut of treatment. So this was literally a last resort, Hail Mary effort. And this is when it just came out. And as anybody should be, I mean, you're always skeptical of new technology. You have reservations about it. So I used it knowing that, you know, it may not work. And the guy came back within 6 weeks and did amazing. Now I did add PRP to it, so that probably added to his success. But certainly having the ultrasound go through, look at the tendon, not make another incision, not have to go through and make more scar tissue for the guy. And he was eager to go back to work. He was a great patient. I was able to find the tendon, get inside of it, and inject the PRP. So that sort of turned my eyes, because that was not a patient that I expected to do as well. So that is a patient that has kind of gone down that road of recalcitrant success, where you just don't know. And then the next patient I had much more confidence in. This was a primary person, huge golfer. I work and live in Savannah. It's a huge golfing town. People don't want to take more than the day off from golf. It's, you know, it's a big driving force for these patients to get back on the golf course. So he came into me and said, I don't want surgery. I have this problem, I've tried everything, and he had numerous injections as well from another surgeon. So I offered him that, and he also demonstrated success within 4 to 6 weeks. So he was another patient who I thought originally would do better than a workers' comp, but they both, the one thing that pointed out to me was that their success and their pain-free clinical exam was somewhere between 4 and 6 weeks. It wasn't that classic 8 to 12 weeks that we see with surgery. We talked about the success rate. Steroid injection, somewhere between 50 and 75%. Surgery, I believe, is north of 95% in my opinion. With the Ocelot, I'm 8 for 8 so far. I think you're going to find the results are somewhere between 90 and 95%. It's not going to be as good as surgery, but it's going to be better than steroid injections and PT. Adding the PRP is going to bump that number even up higher. And I've certainly, my anecdotal results, while they're small, I don't have a ton of patients yet, we just started using it a few months ago, are going to push that number close to surgery. Probably never pass it, but it'll be close. And I'm looking forward to that, because what you're going to do is you're going to find an option that's cheaper and almost as effective as surgery without all of the downside of surgery, the pain, the expense, the long recovery time, you know, et cetera, possible infection, you name it. There's a lot of reasons to avoid surgery if you can, and this is just another way that we're pushing medicine forward to achieve the best outcome we can with as minimal downtime and as minimal expense.